Good morning, everybody. For those of you who don't know me, my name is David Nicholson. I'm the chair of the Worcestershire Acute Hospitals NHS Trust. Welcome to this board meeting this morning. It's live on YouTube at the moment, so good morning to anyone out there who's listening. I've got some introductions I think to make. We've got a few people here. Can I first of all welcome Danielle, who's in my top left-hand corner, but I'm sure is not. Welcome, Danielle. Danielle is going to do one of our patient stories later on, and we'll have the opportunity to talk to her. Welcome, Danielle. We've also got, I think, 3 colleagues from NHS E&I, who of course we love dearly, who are helping us with our well-led review work, trying to make us a more effective and better board. They're sitting in to observe today. So welcome to Sarah Thieker, I think I've got here. I've got Oliver Newbold, and I've got Carolyn May. So welcome everybody to that. So let's get moving. We've got a lot to get through, and as many of you who've seen board meetings or been at board meetings before will know, we're trying to start the board meeting off with a patient story. That's really important thing for us because of the services that we provide, and gives us a direct connection with patients and people who are engaged in using our services, so that we can listen, reflect, and engage with them and think about how we might improve our services going forward. So welcome, Danielle. Is Robin here as well? Yes,
yeah, Robin's just arrived.
Yes, I can see Robin. Hello, Robin. Welcome to our meeting. I'm going to hand over to Vicky now, who's going to do an introduction, and then we'll take it from there. Vicky.
Thank you very much, Chair. So very welcome to Danielle and Robin, and we've also got Amrat from the Women and Children's Division. I don't know whether Sharon was joining us, Amrat. Oh, no, that's fine. Okay.
Sorry, Vicky, having mute issues. Yes, Sharon Ali and Anya Wright, who's the manager for neonates, is going to be joining us as well.
Okay, so we'll welcome them as they arrive. But you've all have had an opportunity to read through that. But fundamentally, this story shares how the digital measures that we implemented at Worcestershire Royal Hospitals have supported families through a challenging time, because the importance, as we all know, is the timely connection with babies that have been delivered, and actually the experience for mums and babies in that bonding process. And in meeting Danielle and Robin, I think it was Tuesday, wasn't it, that we met and had an opportunity to reflect on their stories. Both of them, I thank them for sharing their experiences, both a couple of months apart in terms of when they delivered. But what I would ask, Chair, is if we could go to Danielle first. She's going to share the sort of context before she came in, some of the anxieties that she got before she came into the unit, and how this experience has supported her. And then if we could pause for questions for Danielle, because I know, Danielle, you've got an appointment for that, and then we'll move to Robin, if that's still okay, Robin, with you. So if I hand over to Danielle just to share your story.
Hello, can you hear me okay?
Yeah, we can hear you fine.
I'm sorry if you hear my dog. Be in the other room. So I have a little boy called Samuel. Previous to pregnancy, I suffered from depression, and I've read about the link between postpartum depression and having depression before, so it was definitely an anxiety of mine, and I was made really aware about the importance of skin-on-skin contact after birth, and the importance of releasing those oxytocin levels to produce milk. So when I had an emergency C-section at 30 weeks, that was the first thing that I was concerned about. And so obviously after I gave birth to him, I was taken to a ward with mums and other babies, and the only thing I could do, I didn't even know really what he looked like because I was in such shock. And so the only thing me and my husband were thinking we could do is to produce milk for him, and that's the only, I can't hug him, I can't do anything else. And it's so hard to do when you've got other mums and their babies. So when they suggested the iPad, it was such a relief, because then being able to see him and see what he looked like, and just confirmation, yep, that's my baby, I can see that. And it just helped with the milk production so much, and it was just brilliant. And I tend to do that at night time, and just be able to look at him and get the milk production. And the staff were just so brilliant. I can't thank them enough. Any questions?
For sharing that. I think everybody's great. Thank you for sharing, Danielle. So, David, could I pass back to you to pick up any questions for Danielle before we move on to Robin?
Yeah, of course. Danielle, thanks very much for that. Did I hear the little boy's voice in the background?
Yes,
Was he there?
He's chatting.
Am I allowed to see it? Anyway, that's neither in there. But it's nice to hear. Nice to hear from him and his contribution to the discussion.
Here he is. He's gone.
Ah, right. Okay. Very good. Lovely. It's seldom do we get things like nice things like that at the board meeting. So thank you for that, Danielle. I mean, it must have been, I think, very difficult in the circumstances that you found yourself in, and none of us want those situations. But do you think there were things that we could have done which would have made things better, that we could kind of reflect on and think about for the future?
So there are things like, so staff were really tried to accommodate the best they could. But I'm obviously, with anxiety, I always feel guilty. So I did feel very guilty asking for the iPad. So I don't know if there's like a system, I don't know, like, and also comes with that is technical difficulties. So I don't know if there's like a better way of like making sure the staff know about the iPad, and maybe have more iPads.
Yeah.
Because also, I don't know if you know this, but I was able to invite my mum to look at Sammy as well. And I'm not sure if you're aware of that, but that's also a great thing, so that you can let families know that they're able to do that, get their family involved as well. And also another thing was I don't know if you were able to get like a sort of bracket, because the staff would spend ages trying to get the perfect angle so I could see him. So I don't know if you have something that can make it a bit easier for them to maneuver the iPad.
Some lovely suggestions there.
Yeah. Any other questions or comments before we move on to Robin?
Chairman, could I just make a quick comment, please?
Yeah.
What it is in relation to what Danielle said about nurses always being too busy and in your own belief, and you're not quite sure ever to ask. Just to pass on to you, I was at a ward visit where a nurse made the statement, and they were trying to put it into a sign to say, "We are never too busy for your questions." And if that type of signage was up, I think it would definitely help our patients across the hospital, let alone within our maternity and neonate area, because the nurses were absolutely keen to make sure that the patients were aware that they're never too busy for the question, even though that may be the belief.
No, that's when I was in hospital, they would always say it to me. But you know, when that's just my anxiety of always feeling guilty. And so, but that was another really positive thing that the staff did. They would always say, no question is too silly and we're never too busy. So, you know, so that was also a good point.
Okay, well, thank you for that, Danielle. We're going to go on now to Robin. If you want to stay, please feel free, but if you want to...
I have to leave. Thank you so much.
Understand.
Thank you.
Thank you. Okay, Robin.
Microphone, Robin.
Hi, can you hear me now?
Yes,
we can, Robin, thank you.
Hi. So my story, basically, I was pregnant with twins, and I went into early labour at 35 weeks, which meant I had to have an emergency section. And the section went well and everything, and we got taken to TCU, which is the Transitional Care Unit, which basically has 24-hour midwives and nursery nurses, so they could provide with extra support and assistance and just help new mums and new families. And shortly after I had the babies, they were fitted with feeding tubes, and they were given their first feed by the nurses, and we're not quite sure how it happened, but somehow Charlie, the smallest baby, ended up with milk in his lungs. So he was found in the incubator unresponsive, basically, and needed to be resuscitated. So obviously it's very traumatic and it wasn't a very nice time. But soon after, well, straight from that, as soon as they got him breathing again, he was taken straight to neonatal, to the intensive care. So at this point, I was it was only a couple of hours after the section. So I was bedbound, which meant I didn't then see him for over 24 hours until I was able to go to the ward and see him myself. And when I got there, he was, obviously there was a lot of tubes and machines and beeping, and it was a real shock and just really overwhelming. And I wasn't really expecting it. I wasn't sure what I was going to expect, to be honest, but it was just a real shock to the system, and quite upsetting. So when I got back to TCU, that's when they suggested to set up the iPad so I could feel a part of it. And then every time I went to visit him, it wouldn't be a shock if there was something different or if something had happened. But it meant I could see if they were feeding him, changing his nappy, and just feel a part of the process, really, because obviously I had Eden, my other son, with me in TCU. So we were completely separated. So the iPad was it was just a great piece of equipment that I could use just to feel like I had both of the boys with me together. So yeah, and it was just great, really. It made me feel not so apart from him. But yeah, so it really worked well for us.
Okay, thanks, Robin. I ask Danielle the same question, but I'd appreciate a view from you. Were there things you think we could have done better in terms of your care? Some ideas that we might take forward?
I was asked this a few days ago and I've been thinking about it. And to be honest, the support I got given from the midwives and the nurses, it was brilliant and I couldn't fault it at all. We spent 10 days in hospital overall, and it was actually my birthday as well whilst I was in. And they brought me a birthday cake and they made me a card and they made it feel so as homely as it could be. So that side of things was really positive. But after some reflection the last couple of days, I do think that maybe some more support with breastfeeding. I because of the stress and the separation between myself and my baby, I really struggled to produce milk. And looking back on it now, I kind of was left to my own devices. And as a new mum, I wasn't really sure what I was doing. So in the end, I ended up just giving up, really. So that is probably my one regret, that I wish I'd have stuck to it a bit better, and perhaps with a little bit more support, that I would have done, if that makes sense.
Yeah, no, it makes complete sense. Yeah.
What I do want to say though is that they were brilliant, and I really don't want to be negative about the staff, because they were fantastic. But that would be my only sort of word of advice, really. And again, with the use of the iPad as well. What Danielle said about being able to call like parents or family members into the chat so that they could see the baby. I didn't know about that, so I didn't do that either. So perhaps that's something that needs to be known, and for staff to know how to use it as well, because there was only a couple of staff that knew how to set it up. So if all the members of staff knew, then perhaps that feeling of being a bit of a burden or not wanting to ask wouldn't be there, if that made sense.
Yeah, it makes complete sense. And I have to say, we're certainly not taking this as a negative. It's really important, but in order for us to get better, that people tell us so we can do something about it. Are there any other questions that people want to raise?
Anytime, Bill.
David?
Sorry, Bill. Yeah.
Not at all, Robin. I just wanted to see how things were going now, and how are the babies?
They're absolutely perfect. They've put on loads of weight. I've got them beside me, actually. Here you go.
Oh, brilliant.
Can you see? This is Charlie. This was the one that was poorly.
Right.
You can see very well there. And this is Eden.
They look absolutely beautiful. And feeding's going well now, is it?
Yes, yeah. So we came up hospital with the feeding tubes in, and then within 4 or 5 days they were taken out, and they're bottle fed now and absolutely fine. They've put on loads of weight, and we've been discharged completely now. So
fantastic. That's really great news. Really brings us a bit of joy in these difficult times. So well done. Thank you.
Thank you.
Yes.
David, I had a question as well, and
Sorry.
I guess it's not so much for Robin, but it might be for Amrat and Vicky. I mean, long time ago when I had my first baby, but at that point there were lots of sort of breastfeeding counsellors, Lalesh and NCT, and various people wandering around. And I'm guessing in the current situation, that's not happening. Robin's experience about not getting support for the breastfeeding, was that to do with COVID, or is it that we don't have that system now of having volunteers or people from third sector organisations supporting mums?
Shall I answer that, Anita? We actually have, we've never had any volunteers from the third sector in regards to supporting breastfeeding, but what we do have is we have breastfeeding advisors both on the neonatal unit and on the maternity wards as well, and every single member of our staff are all trained to support mums with breastfeeding. So nurses, nursery nurses, midwives, they can all support mums at the bedside as well.
And can I just add that they did try, don't get me wrong, they did try, but there was times when I probably could have done with a little bit more support. But I understand that they're busy and there's lots of other people to see. So I don't want to be a negative.
No, I mean, I think my memory of it was that, I mean, again, this is a long time ago, but I really struggled initially, but I actually I got home and I was on the phone to a breastfeeding counsellor, and she talked me through it when I was at home. And I'm just wondering whether there is actually an action here for us. Should we be involving third sector more? And even at a time of COVID, I mean, it was a breastfeeding counsellor that talked me over the phone to getting my baby to latch on, and it was fine. But I couldn't do that, but I did it by phone. So I wonder if there's something we could be doing additionally, because clearly the nurses and midwives are busy, but I'm wondering whether there are third sector partners that could really help us with that.
If I'm able to respond, I think you're absolutely right, Anita. I think we need to look at every way that we can support mums with breastfeeding, right from just after delivery through within the vision. Now we can pick that up, and I think particularly in terms of a prospective review with mums about how they feel supported in that particular point. I know there's already work that is undertaken in terms of experience and feedback, but we'll enhance that to answer your question, Anita, so thank you.
Okay, let's, any other questions? All right. Okay, well, thanks very much, Robin, for giving us that, that advice. I really do appreciate it. I know it can be quite daunting to do these sorts of things, but very much. I think I picked up a few things from both you and Danielle's views about it. And the first one, just to reinforce the thing that Mark Yates said earlier on, is that everyone's busy. Of course, there's lots to do. Here that we're all paid, that we're all involved in it, is to provide support and services to people like yourselves. So people should never feel that they can't do that. But in terms of practical things, I think that have come out of it. I mean, and this may be, and this is mainly for Amrat, I think, to take on board. But we'll have to, look at each one individually. So, for example, the number of iPads, I don't think there's an issue certainly from this organisation about if we need more, we should get more. The training of staff to use them. I know as somebody who has serious trouble even involved in any kind of iPad. I know that is difficult, but I do agree that having access to being able to connect with family members as well is a simple thing. And if you could train people to enable that to happen, I think that would be a really good feeling. You can never, at one level, you can never do enough, and I'm sure we've got a lot of things in place, but one mother who could have done more but feels now that perhaps she didn't get the support is one too many. So to think about how we might engage ourselves more with other people who can enable and support breastfeeding, I think it would be really good. And so thank you, Amrat, thank you, Robin, for that. And I think you should go and spend time, well, you are spending time with your beautiful baby. So thank you very much for that.
Thank you very much.
Thank you, Robin.
Bye. Thank you. Bye.
Bye. Okay,
David, if I could.
Sorry, Richard.
If I could just come in very briefly on a couple of those points just before we move on.
Yeah. Sorry.
So you're correct to say that the number of iPads is not an issue. First wave of the pandemic and some money that we've got in charitable funds. That's absolutely not. I'm also happy to discuss with Amrat what sort of handles or stands might make life easier for the staff on the wards. I'm pretty sure we can sort that fairly quickly, as well as a kind of user-friendly laminated guide to using them. I think all of those can be resolved pretty quickly. So that's useful feedback and something we can do something about.
Okay, thanks.
The minutes that you can fund. Can I say I don't know whether other people are finding this, but it's quite difficult. The connection is not working particularly well at the moment. And I know this is a problem with using Zoom to YouTube at the moment, but we'll be able to do soon, as I understand it. So I apologise for the disconnections for that. So I missed the point that you were making, Tamara, then. Gone quiet.
We've lost it completely.
Can anybody hear me?
Yeah, we can, David.
Okay. I think that from what Kamara was saying, that we just need to minute the fact that if more iPads are required, we can provide funds to enable that to happen and put that in the minutes. Okay, let's move on. I think Richard's made a note point to us if colleagues who weren't talking could turn. Anyway, you've seen it, so I'm not going to go on about it. Let's move on. I'll try and keep my cool while this is all going off. No, okay. Declarations of interest, they're on the website. Minutes of the previous meeting, are they a reasonable reflection of the conversations that we had and the decisions that we took on the 15th of October? I'll take, but then again he would, wouldn't he? So is there any, I think everyone's fine. Yes, okay, that's good. We'll agree to those. Okay, the action log. Kamara?
I think David Kamara's reconnecting, so happy to step in. The BAME network meetings, we're obviously liaising with Jazz about timings in relation to that and how best to organise it. And looking at the log, the other actions are closed. We've got the date for the finance workshop, and we've got dementia training organised, I think, in December. So all of the actions are complete.
Lovely, thank you very much. Let's move on then to the Chief Executive's report. Matthew.
Thank you, Chair. I hope my connection's okay at this end. Take the report as read. I think a couple of things just to highlight, if I may. October was our Culture and Forward Showcase month, particularly re-emphasising the cultural change journey that we're on as an organisation, which is obviously fundamental to the quality, safety, performance and finance improvement journey. We also choreographed it with Tina and Richard's help and others to make it a sort of celebration of 3 years of the Forward programme, but also promoting the Freedom to Speak Up Guardian role, which we have a report on later on the agenda, and also Black History Month as well. And we've also, whilst now launching our Freedom to Speak Up portal, we also had our first ever Disability Network meeting as well, which I think generally the sense of direction for us is one where we're looking to have a much more inclusive organisation where all of our staff and colleagues feel involved. We also must draw attention to our international superstars, our consultant paediatrician and play specialist who appeared on TV, all corners of the globe, with their rendition of Swan Lake. We also continue on the flu vaccination programme. We should celebrate and congratulate our colleagues with the Health and Care Trust, now that they run mental health services for Herefordshire. They have changed their title to Herefordshire and Worcestershire Health and Care Trust, and wish them well in their endeavours in Herefordshire. Obviously, we've already touched on some patient and service user feedback from our maternity services, and as SRO of the STP's maternity system, I'm pleased also to report that we now have an innovative app now available for mums to get real-time information about their pregnancy, this Badgernet system, which has now been fully implemented. And also just to mention, particularly because of the media coverage on long COVID, Mike Halliday has stepped forward on our organisation's behalf to try and establish arrangements across the county, and that we will be the lead provider for long COVID support for Worcestershire. And then finally, Chair, just to reference the appendix, which is our submission to the infected blood inquiry. We are obviously working closely with the investigation and inquiry, and we've included here for information, this has been through the Quality Governance Committee as well, in relation to our response to a set of questions that we were asked in relation to our historical involvement in haemophilia treatment back in the 1990s. So I'll pause there, Chair, and happy to take any questions.
Any questions? Yes, Richard Ostrom.
Thanks, Matthew, for the update. Can you say something more about current progress of the vaccination, of the flu vaccination? Because it seems to me it's even more important than previous years.
Yes, thanks, Richard. And I think Mark's already preempted that by sending the note with the latest vaccination figures. So we're essentially on plan with the rollout of vaccination as per the national guidance around prioritisation of staff, and we're obviously looking to continue to progress to as high a percentage as we possibly can. Obviously 90% is what's been set as the standard that we should be working towards, but I think given, as you say, the particular circumstances this year, we would want to be getting that number absolutely as high as we possibly can. Preparations are also underway across the county for the COVID vaccination planning, and we're obviously working with that, although the Health and Care Trust are the lead organisation for the county in preparations for staff vaccination.
Okay. Are there any other questions? No? Okay, thank you very much for that, Matthew. Let's move on then to the board assurance framework.
Thank you, Chair. As ever, the board assurance framework updated 3 times a year. We go through quite a detailed process with making judgments on our key strategic risks against our key strategic objectives, and also our annual plan priorities. You'll see the latest iteration, which has been through, as you can see on page 1, various discussion and approvals at board subcommittees where the risks are aligned with the specific agendas of each of those subcommittees. The particular reference for colleagues on page 17 of the pack are those key risks where there is the furthest distance between our target risk rating, and we want to manage the risk down to, and our current risk rating. And as you can see risk 12 at the top in relation to our ability to hit the national phase 3 restoration plans whilst trying to effectively manage a busy emergency workload and an increasing number of sick patients with COVID positive results in the organisation. And no doubt we'll cover some of that in a paper later on the agenda. The next key risk relates to our ability to implement our clinical services strategy, with our particular focus on making sure that each of our key hospital sites has a specific role. And we've made good progress actually in that regard during the COVID period, but we remain of the view from an executive level, as well as the subcommittees, that there is still some further work to do. And then we've also added in there the question of technology, life cycle maintenance, and cybersecurity protection because of our legacy infrastructure as an organisation around our technology platforms that we're working from. And like as aligned to that, we have a new risk that's come onto the board assurance framework this time around, which is risk 13, which is the reference to that technology infrastructure. So that's a new risk for this time round. And I think I'll pause there unless, Kamara, you have anything particular to note to take any questions. But as I said, the specific risks have been discussed and approved at each of the board subcommittees. Happy to take questions, Chair.
Thank you, Matthew. Any questions, comments? Some of these bigger risks we will undoubtedly be dealing with later on in the meeting around restoration and clinical services strategy. Any other? Richard, I think. Richard Oostrom.
Thank you, David. Matthew, are we sharing the buff with our system partners, given the fact that we have so many mutual dependencies these days?
Yeah, it's a really good question, Richard. I think through the course of our operational and strategic discussions in places like the Integrated Care System Executive and also the A&E Delivery Board, we are actively discussing these points, and they are very much featuring in the agenda. But in a sort of sense of, are we saying these are our key strategic risks on our board assurance framework, and therefore we want to bring those to the table for a formal discussion? We're not quite as formal as that, and that's something perhaps we can take away and have a think about. In terms of sharing the key challenges, I mean, I meet with my chief executive colleagues and the local authority leadership on a weekly basis every Tuesday afternoon, and we're very much discussing these issues. So we have good structures in place to do that, but the formality of sharing our board assurance framework hasn't so far featured. So it's perhaps something that we can certainly develop.
I think from the perspective of the ICS, this is quite a big issue, Richard. I think that if you think about each of our board assurance frameworks for activities around audit and assurance generally across the patch, whilst there are some informal contacts, it's not systematically organised. And I do think that's an action for the ICS to think about how more formally systematise that discussion to ensure that the overlaps and the mutual connections are strongly made. Okay, Bill, I think you've got to say something.
Could I just say, from the Quality Governance Committee's perspective, we found the BAF an increasingly useful tool. It's a living tool that we actually now find real utility from. So I'd like to just congratulate the executive on the great progress they've made with the BAF, but also standing back one step, we've seen risks reduce. And I think that's an important message. Through all of the challenges we're facing with COVID, we are making measurable progress with our risks. And I think that's really good news. So it's to really share that with the board.
Yeah, that's a really, really good point. Colin, do you want to say anything about this?
Thank you, Chairman. I'm encouraged to hear Bill's comments, because in terms of the governance steering group, we are continuing to look at the BAF as a key plank in the overall governance structure, and to work towards seeing that it's integrated so that it's part of the overall governance structure, and as somebody has already said, a living document. And I think we have made progress. I think Kamara has said that she feels that the BAF is in good shape at the moment, but there's still work to do. And interestingly, I think one of the developments that we've agreed at the Finance Committee through Richard's chairmanship is that we're going to do a deep dive every couple of committees into specific aspects of those items on the BAF that relate to Finance Committee work. And I think that's something which will, if it's replicated elsewhere, would bring to life the document to a higher degree.
Yeah, thanks, Colin. I would concur with that as well. Matthew.
Yeah, just thanks, Chair, and Colin's point. I think one of the things that we had suggested with Bill as well is that we perhaps the last meeting, Bill, we talked about that as well, about whether we could do that across the subcommittees. I think that's a good discipline. And not only does it give us the opportunity to really scrutinise our risks, but it also gives us the the opportunity to make sure that we've got that good alignment between our corporate risk register, the divisional risk registers, and therefore the strategic risks. So I think that's crucial. I think the second point is increasingly the strategic risks need to inform the agendas of the subcommittees, and we're doing that already. But I think the deep dive structure gives us that extra sense of strong alignment between subcommittee agendas and the key strategic risks.
Yeah. Very good. I mean, to an extent, this is a bit like the integrated performance report. You know, we should never be satisfied with it. You know, we can always work on it and improve it, but it's certainly, I think, in a decent place for where we are now. It's one of those little documents that I carry around with me all the time, just to remind myself of it all. So in the sense of it being a living and a useful document for us all in what we do, I think it's becoming increasingly significant. So thanks for all that. Thanks for everybody who's put the work in to make it better. We need to approve the revised BAT and the arrangement. Can I have that approved by the board? I can. Lovely, thank you very much. And as I say, some of the issues will undoubtedly come up as we move along. Let's move on now to restoration and recovery. Is this a double act, or is it or Paul? Or...
Thank you, Chair. I was going to suggest if I just introduce the paper and comment on a couple of bits relating to my side, and then invite Paul to speak to the COVID and the restart service elements. So I'll assume everybody's read the paper first of all, and just wanted to note the progress that is being made now with the HICS, and you'll see that we've got some particular successes around some of the rollout of the HICS 1 and 2 in terms of the advice and guidance. We're trialling the electronic triage and the work with the outpatients in terms of follow-up calls. In terms of a dashboard, we're working on that for the next meetings and the benefits realisation work. The only other bit I just wanted to highlight was at the end of the report, you'll see that we referenced the annual planning process for next year. Clearly, we're a little bit behind where we started last year, which was August and September, due to the phase 3 work that's being done, and now COVID wave 2. We've taken this to CTM this week, and it'll go to TME in terms of the detailed planning and process. But we are obviously having to manage within some very challenging operational constraints to make sure that this important planning document we managed to work through in the same rigour that we did last year. So that's really just to note. So unless anybody has any points or questions for me, I'll pass to Paul to talk about the operational elements.
Paul, are you there?
Yeah. Shall I just run through the up-to-date figures? Clearly, the figures in the board report on page 3 of the report, which I think was page 50 in the pack, were at the time of writing the board paper, and things are moving on quite rapidly. So if I just give a brief summary so that you're updated as where we are today. So we've kind of identified that the second wave started to come through round about the 28th of September. And we started seeing a kind of two to three new positive patients a day, offset by discharges and unfortunately deaths. Then from about the 16th of October, the numbers started to increase, where we were seeing around about 6 positive patients, 5 to 6 new positive patients being admitted a day. At the current position this morning, we have 63 positive patients across the 2 hospitals as inpatients, and that's the highest number since the 1st of May. So that gives some context. In terms of deaths, at the beginning of the second wave, which I said was around about the 28th of September, we'd had 281 deaths, and that number now stands at 304. So 23 deaths since our kind of position of the second wave. Staff absences have also, due to COVID, have also increased. Just prior to the beginning of the second wave, that stood at 49, and this morning that's 224. In terms of overall numbers we've seen since the start of the pandemic, as I said, we've had a total of 304 deaths and 649 patients who have been admitted but discharged with COVID, giving a total of 953. We've also started to peak in ITU, which we did at the beginning of this week, when we had 17 patients across our ITUs, which is the highest we've had for since June. And this morning it's dropped a bit to 12, but we now have our surge ITU open at Worcester. So the main ITU department at Worcester is now for positive patients, and Akenbury 2 has been opened up for green patients. At the Alex, we're still using the main department. We keep a side room in the main department for green patients if necessary, but basically the ITU at the Alex is positive now, and we are just finalising plans which will go to the Gold Command for sign-off tomorrow, which will set the path for the surge ITU at the Alex, where we will increase capacity by a further 4 beds going into Cedar Ward. If we have to enact that, which would be when we have 7 patients in the department at the Alex, then that will then start to have an impact on other services because of the redeployment of staff. I'm sure you're all aware, but for each ITU bed we open, we have to relocate just over the equivalent of 5.2 nurses. So an additional 4 beds would be around about 21 staff, plus putting in shadow, trainee and consultant voters. So I think that's where we are in the position as at this morning. The other change to the paper, when the paper was written, it identified that we had 188 of our beds on COVID pathways. That's now increased to 206. And we have our transition plan for the next wards to go from green to cohort stroke positive at both Worcester and the Alex. And if we had to enact that, that would switch a further 48 beds. In terms of the restoration, I can't really give much more of an update than there's in the report. For September, against the phase 3 plan, we were at plan for endoscopy, for CT, MRI, and day cases, just slightly below the plan for inpatients and below the plan for outpatients. But we have been increasing our capacity on the outpatient side. One of the challenges that we've had is that we've had to use outpatient accommodation for our clinicians to do virtual consultations as well. But last week we had very good support from colleagues in the County Council, and they've now given us rooms in the County Council's building at the back of the hospital, and we're using those for running virtual consultations, which has then released capacity on the main site for face-to-face work. And then the only other major change that we're doing as part of the phase 3 restoration is we are relocating our pre-op assessment out of Mulberry and undertaking some works in Mulberry so that prior to Christmas we will be able to reopen the AEC for the urgent care emergency pathway. So that's where we are at the moment. Happy to take
Thanks. Thanks. Well, I've got Colin, I think, wants to ask a question.
Thanks, Chairman. Going back to Joe's remarks about the annual plan and the planning cycle that we're about to go into, I think we've made a lot of progress with the board reporting, and we've been able to track pretty well, I think, where we are with the current plan. But the thought occurred to me, would it be helpful, notwithstanding the pressure on the executive, to have a sort of half-year review? What has it looked like? Where have we made significant progress? What's fallen off the radar because of COVID, etc.? Because for me, that would give a good context to the next round of planning.
Yeah, thanks, Colin. Matthew.
Yeah, thanks, Chair. Yeah, Colin, I think we had got into the business of doing that last year. We brought a report on a half-year review of the annual plan progress. This year, we just haven't had the capacity to do that. But that had started to very much become part of our business as usual. I just think this year that team have just been far too stretched to look back on the annual plan objectives and look at progress. So I apologise for that. I think what we've been spending our time doing instead, and we've done this now twice since the beginning of COVID, is to look at our annual plan and really try and reduce the number of objectives and therefore priorities to help our operational and clinical teams really to focus on the most important things that we want them to. So we've kind of gone, we did a reprioritization in May, and we've just completed that again, and that we felt was more important perhaps than a year, half yearly review, given the unprecedented circumstances that we're trying to work in at the moment. But to give you the assurance that will be part of our business as usual once we return to some sort of more stable environment.
Okay. I mean, anyway, in order to do the plan for next year, you will have to look back to work out to do that. We can think at that stage, I guess, in terms of the work that people need to do. Julie, I think, has got a question.
Yeah, I think, Paul, we said last time there was agreement that there'd be no more than 10 patients who were ready for discharge that were waiting, and we mentioned it broadly in the paper, but not in detail. How is that going? Have we got patients who are ready for discharge and can't go?
Yeah, we've still got those. The number above 10 is falling. If you recall, last time I was saying it was running at around about 27. It's now running at about 16. So it's going in the right direction. Matthew and myself also had a meeting with Paula Fernell from the County Council, Sarah Dugan and Mary Gay yesterday, and we've had one of our colleagues, I brought in Kathleen Simcock, who is going to now take on the role from this week as the system-wide lead for discharge, and colleagues, particularly Paula at County Council, have made it clear that they're kind of giving the authority for Kathleen to direct resources across the system where it's felt to be needed. So Kathleen will now take on that role, covering the whole system for both health and social care, and will be able to direct resources to seek to get to the position where actually we don't even want 10, we want less than that. But progress has been made, but there's still more to do. And we do also tend to find, Julie, that the progress can be variable by the day of the week. So Saturday, Sunday and Monday tends to have a higher number of people ready to go but not going, and then that number tends to reduce Tuesday, Wednesday, Thursday. So that variability needs to be smoothed out.
An individual who's the system lead for making sure all this works?
Sorry, David, I didn't quite get that.
Sorry, from what I gathered from you, we've now got a system lead. One individual is responsible for making sure all of this works.
Yeah.
Who is it?
Her name's Kathleen Simcock. I brought her in to provide some support in the trust on the capacity management side, and so she works for us, but is joint funded now. She was brought in for a specific purpose, but is now taking on that role, and is joint funded by all 4 partner organisations.
Right, very good.
And will report into the Q's group every Friday.
Yeah, Chair, if I could just add to that, I think one of the step changes, Julie, that I'm seeing is particularly Paula Furnivall from the local council really pushing system partners hard to really be focusing on making sure that home first is an absolute priority for all services. Because there's no doubt that Worcestershire historically has had too much dependence on bedded care, when earlier supported discharge with proper packages of care is the better and cheaper way of delivering health and care. So I feel a bit more confident than perhaps last board meeting, Julie, when I referenced the no more than 10 patients at 5 o'clock each day, and as Paul said, we are making progress, but again, not satisfied until we get below that 10.
Okay, thanks, Richard. Richard Oostrom.
Thanks, David. You were quick in seeing my hand being raised. In relation to this topic, in the Netherlands, there was a very active discussion of giving a larger role to primary care, and then being able to release COVID patients sooner than they did in the past. So actually reducing the stay and giving a bigger role to primary care. Is that something that is being discussed here? Is it working here? Would it help?
Yeah, thanks, Richard. I think, Mike may want to comment. I see Bill's hand go up as well. I think the way in which we are now working as a health and care system in the county and across the STP, where GPs are much more involved, I think has been a positive step forward during the COVID period. But I think our GP colleagues are continuing to try different ways of making sure their capacity is as well utilised as possible. But of course, this week we've seen announcements that their leadership role in the vaccination process is going to be quite significant. So I think the tension here is about capacity and also the way in which perhaps it's easier in a hospital setting to coordinate and coalesce our hospital doctors than sometimes it is in a more differentiated environment such as primary care. But my sense is that the relationships are improving, but I think general practice is going to struggle with its additional responsibilities that have been announced this week, would be my sense. But Mike may want to add from the clinician discussion, and I know Bill waved his hand as well.
Yes, if I come in,
yes, Mike, sorry.
In terms of pushing people out, we've got much tighter criteria, and our number of patients going out early is much greater. So as soon as they're fit to go, they're going. I think our last figures I saw, our length of stay has come down from 5.2 to 4.9 days. So the work that's going on is identifying people who are fit to go, and the whole system is much better at taking those people through. So there's more simple discharges, pathway 1. So they're going back with GP-led care. But the GPs are feeling enormous pressure, and I was on a meeting just before this, which Mark was at, and the requirements for GPs in terms of rolling out the vaccine is going to be quite significant, not necessarily just about their own capacity, but actually how it will consume their practice resource. So I think they're going to be quite challenged over the coming couple of months as that vaccination programme rolls out.
Bill.
Thank you, David. There are 3 things I wanted to say. First is to thank Paul in particular for doing such a fantastic job. So this is the most challenging phase of trying to restore services and deal with a second wave, and I think you're doing a great job, so thank you for that. The second point I wanted to raise was around end-of-life care and the choice of patients being admitted to both the hospital and the intensive care units. My own experience at UHB was that COVID was being seen as a little bit of a golden ticket which was distracting people from making the correct decisions about whether care was appropriate or not. And I'd just like to sort of re-emphasize that and encourage our clinical teams to really still bear in mind that COVID isn't a golden ticket. We should treat our patients as whole people and make sure that we're giving the best care for the right individuals. And then the third point was just about my concern around the ability of our staff in their diminished numbers to cope with this from a physical and mental perspective. We're seeing tremendous morbidity in our staff at UHB related to the pressures and stresses of work. And it's just to re-emphasize the importance of supporting and caring for our staff, ensuring they have adequate breaks, ensuring that they get some periods of time away from the work, from the rock face. And those are the three issues. So thank you.
Chairman, if I can just come back on the second one, the third one that Bill raised, in terms of end-of-life care, we've actually got a good partnership with our hospices, who are now able, during this period, we've got a pathway in, which means patients attending ED can be taken straight out on a pathway to hospice. So that's in place now, and that's because of the work the hospices have done. They've been really helpful. And in terms of your comment on staff, I mean, absolutely. I mean, I think the biggest concern we have as an exec is actually staff and the pressure that they are under. There's a bit of relief, if you like, coming out from the first wave. Then we got straight back into restoration and trying to do more work to get everything turned back on. And now to have this kind of second wave that is climbing on a daily basis is really putting a lot of pressure on colleagues. And we've just got to watch out for that and make sure that we're able to intervene and support, because we're having to manage the emergency pathways, the critical care, and then the split between the cohort positive and GNA facilities is a real challenge. But the hospice joint partnership is really good.
Can I come back, David? Thank you very much, Paul, and it speaks of the great work you're doing. The respect forms, the respect process, is that really being embraced, and is that happening in the community to help support this work?
Can I come in, David? Can I come in, David?
Sorry, yes, I said it. Sorry, yes, please.
Oh, sorry, I missed it. Everybody froze. Sorry. I think I was just going to make comment, but also I can therefore respond to Bill on that point. I think in terms of the integrated care of older people and the platform that we've got across the system, there was massive enthusiasm, but also recognition that some of the restrictions of COVID equally gives us opportunities. So, people haven't got to travel for meetings. We've got these social platforms where we can have a very good discussion and agree the system-wide action. So I think there are a lot of opportunities. And I think, Bill, that includes the respect agenda. We've got meetings with GP colleagues because they were present where they've not normally been able to be present because of their commitments. But this social platform provides them with an opportunity to more easily engage with the conversation. Then we can get some real agreed actions in terms of respect, both out in the community and how we monitor and provide feedback to system-wide partners in respect of that one issue, but across the range for integrated care.
Okay, thank you. I need to move on now, but can I just say a few things in summary? I think, first of all, I'd reiterate Bill's superb job taking this forward in under extraordinarily difficult circumstances. And I think in a sense, it makes a reality to our mission and our ideas about putting patients first, because not only do we want to provide great care for people who have COVID, but we also want to sustain those other myriad of services to our other patients who require services as well. And that is the complexity of what we are trying to do. But it's really important that we as far as we possibly can, make that make that happen. And so I'm sure you won't be surprised from the board, Paul, that we need to keep going with as many of the services as we possibly can. Of course, based on the views about patient safety and what is practical. But in line with that, we can also, in terms of strategic services around to the kind of places that we need to in the future. So concentrating elective care in parts of the ALEX, for example, as part of our ongoing development is an important opportunity, I think, that we can take as we go through all of this. So I think we would note the current COVID position. We note the progress in relation to the phase 3 plan. We note the progress in relation to the high impact change programme, and we would endorse all of that as a direction of travel. So thank you. Let's now move on to the integrated performance report. Sorry, before the final point I was going to make, that as an introduction to this, of course, is that I think the board completely takes the view about the importance of caring for staff in all of this. And we're going to be discussing that, I think, in this performance review as part of the thing. So we'll have a better Paul has made. Okay, let's move on then to the integrated performance report. Matthew.
Thank you, Chair. The paper, I think the overarching paper, I think, identifies some key areas for us in the integrated performance report, as you've said that we wanted to identify. I'm going to hand over to Vicky just to summarise those key points. We also want to make sure that we draw out, Chair, the particular elements of the performance report where assurance levels are lower and therefore perhaps areas where we ought to spend a bit of time discussing. And in addition to the 4 areas I've outlined, which Vicky will expand on, and therefore other colleagues will take the answers to the questions posed, we also want to reference our sepsis progress with the sepsis 6 and the ICE reporting, which were discussed in some detail at the Quality Governance Committee. So I'll hand over to Vicky just to outline the key areas where the executive feel that we ought to spend some time during this meeting, just exploring in a bit more detail. So over to you, Vicky Lewis.
Thank you, Matthew. Thank you, Chair. So this is the integrated performance report for month 6, September for 2020. First of all, just to pick up the format of the report. So we've been refining and enhancing it over a number of months. And hopefully it's slightly more concise this month than it was last month. We've taken away some of those indicators, perhaps don't add the value for the trust board, but are discussed in absolute detail in TME and various subcommittees as well. I'd also like to draw your attention to page 117 in your pack, which is actually an infographic. So the monthly numbers, something certainly that the information team were really proud of in terms of reporting and pulling together. And we used on senior leaders brief, and it certainly landed very well. In terms of the 4 areas of key challenge that we have indeed picked up, very much talking to some of the conversations earlier on in the meeting. So we've identified the impact of COVID-19 on our elective activity, and we've just been through some of those challenges with Paul and Joe. The impact of hospital-acquired infections, so our sepsis 6 bundle and our ICE reporting actually have an assurance level of 2, and we discussed that in detail at the QGC committee, and we'll be doing performing some further work on that ICE reporting section particularly, and I know Mike and Vicky will come to talk at length about that. And then obviously absolutely demonstrating, worried about the well-being of our staff and what we can do to continue to support and cherish our staff as they come to work in these circumstances, and ensuring that staff offer around health and well-being is visible for all, and that we're making sure that we're constantly refining and reviewing that as well. And then the finance piece. So our financial position, particularly as we start to talk about the annual planning process for next year, it's a really difficult challenge. How do we get our activities aligned correctly, and what is that PBR or non-PBR or block payment function going to start to look like? And I know Robert will certainly spend some time discussing that. I'm happy to pause there, Chairman, and pass over to colleagues and other executive colleagues if they wish to ask questions or comment.
Okay, thanks, Vicky. And I think that, I mean, I would reinforce the fact that, you know, we'll never be satisfied with the integrated performance report. This is the format of it, not the content. We definitely won't be satisfied with the content of it, but actually this is, I think, moving in the right direction. I particularly like the benchmarking data, which is so often uncomfortable, but I think really quite important for us to understand where we fit. So there are three areas, I think, that have been identified here that we will just want to focus our attention on. The COVID elective activity, I think we've, haven't we, Paul? We don't need to go this again, do we?
No, Chairman, no.
Okay, that's fine. So the impact of hospital-acquired infections.
Thank you, Chair. I'll take this section as read, but also if colleagues would like to look at the appendices where there is more detail in terms of the levels of assurance for this section and also the specific actions that we're taking. But I think this outlines what we've been discussing in the board in terms of the complexity of managing COVID-19 patients through the organisation for both patients and staff, and also the asymptomatic nature of the pandemic in terms of managing those cases. I think particular focus, which we discussed in detail with Bill as chair in QGC in terms of the MSSA and some of the actions that I've pulled out in this section that particularly highlighted a specialist medicine in terms of making sure that we reduce the impact, because we've already breached the trajectory for the annual amount of MSSA. We want to make sure that we're rapidly learning from that and implementing the actions. So that's pulled out in that section and in the appendices. But I'm happy to pause there and to take any questions.
Okay. Bill, what's your response to this and the conversations in QGC?
So I think both the format of the report and the way that the data has been presented has allowed us to question and seek out the intricacies of why things weren't going so well. So it's been really helpful, and I really like the report. In terms of the debate and the questions we had in QGC, they were very openly discussed, and I think it's been a very constructive way of looking at a problem. And seeing today's board report shows that the comments made in the committee have absolutely been taken on board, and work is being done in accordance with that. So I'm very, very gratified by seeing this report and knowing that Vicky and Tracy are working hard on the MSSA issue. I think we've still got to wait for the results. So I'd like to see in next QGC the outcomes of the audits and looking at how we are impacting, particularly on cannula care. And I think that, I'm sure that's clearly been introduced as a clear focus for the way ahead. But I've got great confidence that Vicky and Tracy will come back with improved data next month.
What did you discuss? What about the COVID acquired infections, Bill? Did you discuss those?
We did, and at the time of our meeting, the passage of COVID between staff and patients and staff had actually been in abeyance. So I think the general measures that have been put in place to protect our patients are actually working well. And so the evidence that we saw was actually very encouraging. Clearly, we've got another huge bout in the second wave where the prevalence of COVID in our population, in our patient population group, will be much higher. And we'll have to see, and we'll keep a close eye on potential transmission within the hospital.
Okay, thank you. Any more comments on the Vicky?
I think just to build on what Bill was saying, in terms of COVID-specific actions, then through our command and control process, we're very carefully tracking any revised guidance, but we're working to all of that specific national guidance, but also making sure that we use the National Board Assurance Framework for COVID, which obviously CQC have interviewed each trust against that framework. and we're satisfied of the levels of assurance that we've got, and so we remain at an assurance level 6 in terms of everything that we need to have in place and continue to have in place to support patients and staff.
Okay. Thanks. Thanks. Can we then move on to demonstrating the well-being?
Sorry, David, you went very quiet there. Could we
sorry, I'm nobody here. Okay, demonstrating well-being for staff is the the third area of your report, Matthew.
Yeah, I'm going to ask Richard, in Tina's absence, just to outline some of the key headlines, given that, as we've already discussed in the meeting, it's a key priority for us and obviously a key concern, hence why we've emphasised it. So Richard, over to you, and I'm sure Vicky and other colleagues will step in as well.
Okay, thank you, Matthew. Yes, I'm speaking to this item on behalf of Tina, who can't be with us. I think we've rehearsed the many pressures that the staff across the trust are facing in their working lives, and I think we also range of personal and domestic issues related to COVID, like the rest of the population. So in those circumstances, putting in place a comprehensive wellbeing offer is a priority, as we've already talked about, and that includes support across a wide range of areas, mental and psychological wellbeing, and physical wellbeing being the obvious two, but also things around supporting social wellbeing, advice on financial wellbeing, and all the work that we're doing to build a positive and supportive workplace culture. We have a wellbeing group that brings together staff from a wide range of areas and is currently meeting fortnightly, and are also encouraging discussions around wellbeing, for instance, in our monthly senior leaders brief, where we start with a discussion. I guess from my point of view, there are 4 areas where I think we need to focus on doing more, because I don't think this is too much. One is, what more do we need to add to the offer in terms of what support are we able to put in place for our staff in or outside the workplace? The second is what more can we do to raise awareness across all parts of the trust about that offer? And that's more than just relying on electronic newsletters. It's making sure that managers have the information that they need to identify where their staff may be struggling, and then have access to information about the support that's on offer. What more can we do to encourage colleagues to take up the offers of help that are available? And it is making clear that message that it is okay not to be okay in these circumstances, and to make it very clear that seeking help of any kind is not an expression of weakness, making sure that we can keep ourselves well to continue putting patients first. And then what more can we do to evaluate the positive impact of what we're doing so that we can refocus and change the emphasis. So for instance, in the first wave, one of the supports that we put in place that was best received were welfare shops, but that's because it was much harder to get to supermarkets than it is now. Now we need to be maybe refocusing on supporting people getting access to deliveries or taking day-to-day worries out of that. The psychological offer is an important one, and we're currently working with Catherine Binney and her team to understand what's currently on offer and how we can make it as easy as possible for people to access that support in the workplace, but also when they're at home, so that when they feel the need, they've got information at their fingertips. And then, as well as that more serious end of it, I guess I would always also point to some of the work that we're doing around morale boosting activities, social activities, and what we can do across our sites as we possibly can, and give staff some recognition for all the hard work that they've put in through the year. And we're working very closely in the comms team with HR colleagues and with the charity on developing some activities and gifts around the festive season.
Okay, thanks. Any questions, comments on all of that? Anita?
Thanks, Sir David, Richard. Sounds like a really good approach, Richard, that you outlined. I really did just want to emphasise the importance of that last one about evaluating what worked and didn't work in the first wave. I think, you know, if I can use some experience from another trust I know well, they've actually realised that in the first wave they had these well-being areas which they sort of you know, which were, you know, took a massive number of to resource them, to have people in there all the time, one on each site. Actually, they ended up being used really as places where people just go and have a cup of coffee and just kind of downtime. So they've completely changed the model this time around. And they've actually realised that you need more of them, more spread out, rather than just central areas for them. And they've realised that actually, even if you have them, the big thing is insisting that people take breaks if they're working on the ward, because you can have as many rest areas as you like, but you won't get them there unless they feel they're able to go and access them. So I think that, you know, that idea of going back and looking at what worked, what you got good footfall for, and focusing attention on the things that really are of benefit, and checking what staff want us to do this time. Really applaud that. So yeah, that was all. Thanks.
I've got Bill and then Mark.
Again, congratulations on the offer, Richard. I think it sounds very good. One of the things that struck me is the issue about childcare over school holidays and the Christmas holiday in particular. It's a peculiar time of year with lots and lots of tensions within that. So I'm just wondering whether there's anything creative we can think about that helps support our staff to ensure they have coverage for their children. I don't know. It's an off the wall sort of idea.
Mark, I'll let Richard come back on that. Mark?
It's certainly something we could look at. I'm happy to feed that back to the wellbeing group as well, and pick it up with Felicity or team on the return.
Okay, Mark.
Thank you, Chairman. Just to say, I was going to mention this when we have the Freedom to Speak Up Guardian, but one of the things we've been looking to do and track through the People and Culture Committee is this staff officer, as Richard rightly says. But there are a number of groups in the Trust that historically have worked independently, such as Freedom to Speak Up, Guardian of Safe Working, the New BAME group, LGBT group, Disability group, and all those, and the Forward Advocates, of course. And now they're starting to become far more joined up. So there are plenty of avenues for staff to have a conversation with somebody that they would, if you like, feel comfortable with, and then them being able to, rather than having to be isolated groups. So we're starting to try and address the mental health issues through giving avenues outside of the normal staff offer. And if you look at our sickness figures with regard to sickness due to stress, anxiety and other mental health issues, although they've risen slightly, they're not running away with us at the moment, and they've certainly come down since the main wave, but we keep a close eye on them as we enter this second wave, because that's a good indicator as to how our staff offer is going.
Okay, thanks, Mark. I will move on from this. I think there's one or two ideas there around childcare. I would kind of add into all of this. You know, this is not an add-on because of COVID. This is the way in which our organisation is attempting to change its culture. You know, we've got to get beside the staff to help and support them, and they need to see us as an agent for doing that. So this is, although this is a relatively specific thing to deal with COVID, actually this is part of the way in which we want to change the culture of our organisation. I mean, it's interesting looking at the national offer, and there is a huge national offer, I have to say. If you go onto the website, look at the People website, and there's huge numbers of things, and take-up has been relatively low. It's your peers, your supervisors, your managers and people that you know in your organisation that create an environment where you can get the support and help you need. So those informal networks or less formal networks that Mark described are an important part of all of this as we go forward. Can we then move on now to the kind of final bit of the, which is the financial position? Now, we are going to have a seminar on finance relatively soon, because it doesn't take a genius to work out that it's hellishly complicated at the moment. You've got an old system, a new system, and a newer system all operating together at the moment. And thanks Robert and the team for trying to make sense of all of this for us and to keep us on the straight and narrow. But we will have the opportunity to have a really deep dive discussion on it at another occasion. But Robert, can I get you to say something about this?
Yeah, thank you, Chairman. And absolutely right. So we're reporting on month 6, which was is the last month of the initial interim financial framework arrangement, where no matter what you spend, you are made up to a break-even position. So I think absolutely right. And we are moving over the next 5 months into more of a system agreed allocation methodology. So that is where we're at, but even that isn't final yet. In month 6, we were slightly adverse to where the funding we were expected, that were part of the initial financial framework. And that's mainly due to the fact that we did continue to see an increase in our activity, and therefore an increase particularly in our non-pay costs, including what had been previously passed through non-PBR drugs and devices, and that's continued in month 7. So we know that's as we've increased the activity, we've started to see increase in the variable costs. We're still ahead of where we haven't spent what we would have expected to spend against the framework, but again, against a very complex position of very different activity to how everything was originally established in terms of the money. I think just moving on to activity, it is clear that we've also, though, been improving the level of activity, and it's shown by the percentage. If we were under the old school PBR in August, we'd have had about 69% of our income would have been under PBR. In September, that increased to 78%. And similar increases of 7 basis points from 62 to 69%. I think somebody's sharing a screen. No, sorry, that's all right. Sorry. Cash balance. So cash is a very good position. We're at £2.8 million. And I think it's just worth noting and recalling that we received in September £324 million, which was used to immediately write off all of our interim DHSS loans. So I think that's quite important just to recognise that it was to help us reset the position going forward. In terms of productivity and efficiency, recognising, as we said in August, there's always tends to be a reduction in the activity that we manage to perform, and that's principally due to staff taking holidays and well-earned holidays. That has improved our activity in September and has reduced, but still not down to the levels of performance that we previously had. Last point, and it's something that we're discussing at greater length with both the execs, but also at F&P, is around our management of the significant capital programme that we've got, where we've actually spent very little to date, but we're making sure, and we've discussed through F&P, that we'll be looking much more at the commitments made, because commitments made this year will also roll over into next year. So we just need to have a greater focus on that one, recognising that there's a focus at the ICS forum, as Colin and I have just discussed previously, and perhaps there's more to update in the private session. But it's just important to note that that's obviously a key area for the trust executive as well, to make sure we can deliver on that and have the right infrastructure in place, whether that's estates facility or IT. And it's probably the largest programme we've had, for some years. The plan also has been updated for the fact we've got an extra £3 million for our critical risk infrastructure to address. and also an additional £1.3 million for the National Diagnostics Replacement Programme. So again, we continue to get money basically given to us, which we need to make sure we spend appropriately. And that's it in summary, Chairman.
I almost at one stage there felt optimistic, Robert, but then it went away. Okay, Richard, do you want to add anything?
Well, you have summarized it well in your introduction, David. I think the difficulty we have is really judging whether we are making a positive impact on, let's say, the financial position we've got in the longer term. We've spent time on the actual controls. We feel the controls on the spend are in place and being applied, but we also feel it's not only not possible to judge progress on reducing the deficit in the longer term, but of course the focus has a bit disappeared from that too, because we are in a crisis and a lot of attention goes to the crisis. So we do have a few concerns about the rise in the bank and agency costs and the PEP delivery, but the main concern we've got is about how are we going to really reduce fundamentally the deficit that we've got in the longer term, which is why the workshop you mentioned is really important next week. I would emphasize what Robert has said on the actual position on the capital spend. Yes, we have discussed in depth our ability to actually spend, which is the opposite challenge we had in the past. We didn't have enough capital. Now we do, but we've got to spend it really, and we properly need to execute. That's it, David. I think Matthew wants to say something.
Yeah, thanks, Chair. Thanks, Richard. Just to reiterate, I think a couple of points. Whilst there is the uncertainty about the income and activity expectations going into next year, as an executive, we are very clear that our focus on our cost base and the way in which we reduce our cost base has to be something that is within our gift. And while some of that is dependent on system partners, there is a fair amount of waste currently in the way in which we work that gives us some real opportunities, I think, to reduce our cost base. So I think when we get together in 2 weeks' time for the deep dive in our board seminar, I think a focus on how we collectively work to reduce expenditure is something that is absolutely within our gift. And also just to reiterate the point about the capacity to deliver the capital programme. Again, this week we have re-looked at that as part of our review of our priorities given the pandemic, and we'll be looking to add in some additional resource, I think, tactically at this stage to help to deliver the capital programme. But there's more a strategic question for us about capability and capacity in parts of the organisation that perhaps historically had been hollowed out, as Chair you've mentioned in the past, where we absolutely need to deliver on some really important capital schemes, some of which we haven't even touched on, such as the theatres programme at the Alex. So there's a lot to do, a lot of really exciting things, but I think we're as an executive trying to just be sensible and pragmatic about aligning resource in the right way. Sorry, David, I'd finished.
Oh, sorry. I don't know whether you've been cut off or something. Thanks for all that. I want to move on from those. Can we now move on to the and as I say, we want to pick these issues up in a much more detail when we get into the workshop that we've got planned. This whole issue of how we're going to make progress to get this deficit down is going to be an important part of our thinking for the future. Okay, thank you for all of that. So if I very quickly, we've got the integrated performance report. So the first bit is obviously the operational performance. Unless someone's telling me anything different, we'll move through that. Just a couple of issues that perhaps if people could give us a note about them afterwards. One of them is a question: why do we do so well on 31 weeks cancer and so badly on 62 and the rest of it? Is this a mathematical issue about flow, or is it something about the way we're doing that now? And secondly, why is our access to CT so low for stroke patients? Seems to be an issue there. So just if somebody could give us a note on that. If we move on to quality and safety, there's a couple of issues in quality and safety. One is the which is reflected in our BAS. One of them is the sepsis 6 bundle, and the other one is the ICE reporting. On the sepsis 6 bundle, it's basically saying, as I understand it, Mike, that we've put action in place. It just hasn't come to fruition yet. So my question is this just a question of waiting for the action, the benefits of the action to come to fruition, or are there other things that we need to do to boost this particular issue?
So if I come in there, I think that it's both, to be honest. So I think we had a lag because we lost support from the team, but I think if anybody logs into the Trust computers, you'll see we've just launched the electronic sepsis 6 training again to deliver on that. I'm engaging with our chief registrar because I think there is a tendency, there's lots of pieces of paper to fill out. You tick the box you think are relevant and then we leave it blank, and that gives us a poor performance, even though we know the outcomes and delivery of the key things, such as getting antibiotics in on time, are being delivered. So some of it is about looking at that. And the third component for me about sepsis 6 is if you look at the number of people who would trigger, lots of them have triggered multiple times, but we're counting every form. So there's a further piece of work to do on that. So I've got a meeting with our chief registrar to try and go through the junior doctor perception of what the issues are, so we can not just beat down on the training, but actually look at where we need, how we're looking at things. So I hope that both the improvement in the training and that will align to give us improved recording. And I have no doubt that when we move to a digital care record, when you can't move on until you've ticked all the boxes, we'll have a much better record of it. What I'm comfortable with at the moment is that we are delivering reasonable care, but we do need to get the recording of what we're delivering much better.
Yeah. Bill, any views on the assurance around that?
Yes, I think Mike is a very good explanation for what we're seeing, and certainly his explanation fits with the data. We are assured that the outcomes for sepsis in the Trust are very good. And so our failure to meet the sepsis 6 criteria are likely to be due to recording. It's very difficult to test out, though, without having the whole denominator to look at. So, yeah, I think Mike's got the most likely explanation. The assurance will come as we see performance improve, but it's quite a difficult area. But I congratulate Mike on his interventions and would add more strength to his elbow. I think one of the issues that strikes me is, though, that the failure to document in the sepsis 6 pathway is a bit of a canary in our overall clinical recording of things, of omissions and commissions. And I think we need to ensure that we don't just say this is a sepsis 6 problem, but it's a challenge we need to keep putting back to our clinicians, that if they haven't recorded it, it doesn't yet count. And I think that's again, a lot will be addressed through the digital care record, but we can't wait for that. We've got to make sure that we can demonstrate compliance with these key indicators.
I do think that I take the point about the outcomes. I think that though we need to solve this issue needs to get sorted, really, and we've kind of, it's been on the agenda for a few months, and certainly if Matthew, when you do your report on the for next month, we can have a kind of a clearer view about what we're going to do. Can I move on then to the care that is effective, the ICE reporting? What's this?
Yes. So what we've been looking at is the proportion of reports that are viewed and filed what we found when I've started to dig into it and understand how the system works, there are huge problems with what we're recording, and that buries the really important stuff. So, for example, in the fracture clinic, none of the repeat x-rays viewed and filed, because they view them through a different system. So we've got a group that's going to work with some of Vicky's team, Graham James and myself, to look through the problems with the system. So if we look at the outpatient investigations, review and filing, it's actually incredibly good, but the total package looks wrong, partly because of the way some parts of the system work. So there's a big piece of work to do to dig into what the issues are, and we've started that. So I think that's going to be a 3 or 4 month project to try and work through how we record the bits that are clinically relevant, as opposed to just recording everything and never quite getting there. So before back in February, where we'll be able to tell you what the answers are.
Fine, Mike. So before I go on to the committee reports, just very quickly, any other points in the integrated performance report people want to raise?
Bill wants to come in.
Could I just comment back on the ICE reporting and what Mike is doing? I think this shows the strength of the subcommittee working and the adoption of SPC charts and all of the processes that we've put in place in terms of governance. This may not have got onto the radar if we'd been doing what we were doing 2 or 3 years ago. And actually the assurance that I have is that we have a system that can ask the questions and might drive through the answers. So although I'm not satisfied with the ICE reporting as it's shown in the document, it tells me the system of governance is working, and I've got great faith in the fact that Mike will, with his group, sort this out, and that we can build in a proper system in the future using our digital care record. So that integration of learning is absolutely key, and I think we're seeing that actually in practice.
Good. Really good point. Yes, Matthew.
Yeah, Chair. Just on the basis of, obviously we've scrutinised a number of the indicators that are causing us concern and a worry. I think we also ought to just note, given that our urgent emergency care performance around ambulance handover delays and 12-hour breaches was a serious concern for us this time last year. The improvement, albeit still more to do, on page 26 of the integrated performance report, with very continuing very low numbers of 12-hour trolley waits. And whilst we've seen a bit of a movement in the wrong direction in September, the ambulance handover delay position has improved so much that we've received some very positive feedback at this week's A&E delivery board from our West Midlands ambulance service colleagues, who are now viewing us as the exemplars in the current conditions that our colleagues there are operating in. And indeed, Dr. Ian Sturgis from the NHSI team commended the long length of stay improvements that we've seen, where we're now the best performer other than Birmingham Children's Hospital, which doesn't really count from emergency care perspective for adults, obviously, and that we're the best performer in the Midlands region on long length of stay patients, which clearly is part of the improvement in flow through our hospitals, which has led to the decompression in our ED departments. Now, I'm not saying we're perfect, we've still got some way to go, but I thought I'd draw attention to the great work that has gone on with clinical operational teams to improve that position, albeit not being complacent that we got it all absolutely fixed.
Well said, Matthew. And Anita.
Yeah, absolutely. And yes, absolutely want to acknowledge what Matthew just said. I also wanted to say, just building on your comments at the beginning, Sir David, I really do like the progress we've made with this IPR. I think it's incredible. It's a great deal more informative. It's a great deal more, we can see what's going on. Just as Bill says, the use of SPC. I love the infographic at the end. So I just think this is a report that I actually look forward to seeing, and I don't often say that about IPRs. So I just want to congratulate everyone involved in where we are. I'm not saying it's a finished product, but miles better than what it used to be. So thank you.
Yes, I completely concur with that. Okay, the two.
Okay. Sorry, Chair. Sorry, Chair. Could I just say thank you to the board, but also note that I'd like to thank the Nikki O'Brien and her performance and information team who work tirelessly to try and improve constantly on this and make sure that we get the relevant information that we need. So thank you, Chair.
Am I missing out anyone else I should thank? I feel you make me feel bad about myself when you say that, because if I'm missing all the wonders of the. But it is true. But you're absolutely right about all of that. Can I then move on to the committee assurance reports? We've got two finance note and the quality governance assurance. Can we note them, please? Yeah. Okay. I'm assuming that any issues that people wanted to raise have been raised during the discussion. Okay, let's then move on. We've got.
Sorry, David, it's tomorrow. Would you terribly mind if we had a 5-minute break?
Yes, fine. If you want 5 minutes. No, it's fine. It's fine. I'm sorry, I'm not being very staff friendly, am I? So if we meet back at 10 to 12. Sorry, Melanie. Welcome to the meeting. I'm sure you found that absolutely fascinating. But yes, we have get back at 10 to 12. Okay.
Thank you very much. Thank you.
We're ready to start? Yes. Okay. All right, so highlighting what Matthew talked about in his report, the culture month that we've just had, where we're trying to bring together a whole series of things to help support and improve the culture of our organisation. And there are a variety of those that he talked about, from the disability group through the BAME network, and central to all of this is the importance of members of staff being able to communicate throughout the organisation with fears and worries and concerns that they might have. If it's one critical thing that this board, between the front line of staff of our organisation and the activities of the board. And an important part of that is the Freedom to Speak Up Guardian. So welcome to Mel. Sorry we're a bit... Mel was recently appointed. You've seen her report, and I'll hand over to her to say a few words. Mel.
Okay, so yes, as you can see, you've got my report. It's a little bit out of date now, as you it was written pre the portal launch. So the main highlights from the report are we have actually now launched the portal. We've got lovely screensavers in the past 48 hours to remind people of this, and that's going really well. And I've actually started advancing it now and looking at how we can triangulate every network's themes on there. So I've had sent an email last night talking about that to senior leaders as to how we can now throughout the organisation triangulate, because obviously I sit on the BAME network and I'm part of the LGBT network, and I'm conscious that the main part of this is to bring it all together, and I see myself as quite pivotal in that role, in embedding that culture throughout the whole trust, not just from Freedom to Speak Up point of view. Obviously we had the really good scores on Freedom to Speak Up, to build upon that next year. Communication and marketing is out there as much as we can be at the moment in the virtual world. Write the piece every week on the Worcestershire Weekly and Champion, showcase a champion, and that's going really well. Champion bio posters are sat with me. Some have been distributed and I'm about to take some to the Alex tomorrow. And education really is a big thing. I've started regional training with the champions. The new ELFH electronic learning for workers has now been launched. So we're going to be looking at how we can launch that as possibly mandatory training for all of our staff, so that they understand the importance of speaking up, so that it's a culture that comes naturally and isn't one that we have to kind of like go out there and sell. So that, I think, really is the essence of what is in my report and moving forward.
Okay, thanks, Mel, and thanks for the work that you've already done in this regard. I just particularly identify, I think, Mark and Steve Williams, who might want to say something about this as well.
Thank you, David. First, I'd congratulate Mel. Coming into this role in the middle of the pandemic, while she's also one of our clinical matrons, and being able to pick up and run with it, and not only run with it, but develop it in terms of trying to knit together all our staff forums and our forward advocates. She's done a really good job, and I think she doesn't only give my committee confidence in what's going on, but I think, from my understanding, she gives the staff and the staff groups confidence in the Freedom to Speak Up process. And so I'd just like to congratulate her on that, and encourage those that aren't aware of the portal, which has just gone live, to find out a little bit more about it, because it's quite a step forward in allowing our staff to put themselves forward, their concerns forward, without having to necessarily seek out somebody. So they can do it in the comfort of their own home, even if they wish to, which gives them another opportunity and avenue to be able to speak up. So I just wanted to bring that to the board's attention. Thank you, Chairman.
Yeah, I would echo what Mark has said. I think it's great that we've rebuilt the momentum that we had in the FTSE role. Melanie's clearly hit the ground running and doing I think, a superb job. And I also love the point that we actually knitting together these different sources of support that we have in the Trust FTSE and the BAME network and the LG network. but also it just gives us so many more avenues for us to really to feel a pulse of what's going on. And I think as members of the board, it's so valuable that we hear from everybody within the organisation, not just through the formal routes. And I think, and certainly Melanie in the role there is a key cog in that. So again, thanks to Melanie, and well done to the portal, and I say for just bringing this all together.
Yeah. Okay.
Sorry,
Anita, sorry, have you not heard me, Anita?
I wasn't sure who you, Anita, right? Okay.
Sorry, Anita, Vicky, and then Matthew.
Just a very quick comment, just to echo my colleagues Mark and Steve's comments. I mean, I do think, Mel, you absolutely have to re-establish the momentum. I think after that sort of gap, I think you've done really well. I just want to draw the board's attention to one particular a bit of data that's in this report that I think we mustn't overlook. The thing that I am particularly pleased about is in the table on the top of page 125 or page 4, is actually in the period since February, there has been only one anonymous concern raised. That is an incredibly important thing, and it's not something I see in other trusts, and it really says that our work on forward and our culture, I'm not saying we've got it spot on, but it actually speaks masses for what we've got right about the culture, and I really think we need to acknowledge that, because I think it's a really important thing. Thanks.
Hey, Vicky.
Thank you, Chair. I think, Mel, I really welcomed your email last night. I think the issues about triangulation, because there's a range of professional, informal and formal networks that we have. I don't know whether I'm frozen. Am I frozen? No, am I there? Can you hear me?
Yes, I can hear you.
Yeah, sorry. So there's a number of professional forums, Mel, that I hold, and others do as well. So I welcomed your email about the triangulation, because that's absolutely key. So we'll catch up soon so that we can start to think about how we do that.
I just think we can use the portal a little bit to our advantage now we've got it, and use it as a real dashboard.
Okay, Matthew.
Thank you, Chair, and obviously not wanting to put a downer on all of this, but of course we the alternative routes for staff to raise concerns, and the key to all of this, obviously, is for staff to feel safe and able to raise concerns with their line manager. And that, I think, is an area that we still, as an organisation, have some way to go to ensure and to empower our staff to feel safe to do that as their first line of raising concerns. Now that won't be appropriate for everybody, but I think we still need to do some further work, and the work that Tina and Paul are doing to look at roles and responsibilities within our clinical management structure and the restructuring of that, I think, is going to be crucial into the longer term to make sure that our leaders and managers really understand that supporting and creating a safe environment for speaking up is a fundamental responsibility of their roles. And so I would commend the work that's done so far, but fundamentally we need to get line management right in this organisation. We have some way to go in that regard.
Matthew, I've got Richard and then Mark.
Thanks, David. Yeah, I don't want to repeat what's already been said. I think it is a great start for Melanie, and it's a really important topic. Melanie, I just wanted to ask, are you also hooked into the community of the junior doctors? Because that's a very important source. Yeah.
Yeah, I linked very closely with Sally Millick. She's one of my champions, and also she is the safety guardian for them. And I do go to the junior doctor forums as well, although they're not very well attended by junior doctors, so it's very difficult to tap into them. But I'm going to be doing, Sally and I have met, and we're going to do some training now with the junior doctors, and we're putting together a training program. So on don't know if I broke up then.
You did.
Yeah, I'm also, Sally Millett and I are getting together to do some training with the junior doctors. So we'll deliver training to them between ourselves. So when they come into the trust, they will have the induction training and know what avenues they've got to explore.
Okay, thanks, Mel. Mark.
Yeah, just quickly on that one, as a result of the junior doctors coming to People and Culture, Sally's done a great piece of work in record, because those 3 junior doctors all said we don't know anything about freedom to speak up. So as a result of those comments, Sally's put in a quite extensive piece of work with Mel to try and put that right. But the piece that I was going to mention was Matthew's absolutely right. If our first line managers don't get this right, then staff do need these other avenues. And just to add to what Matthew said about roles, lines of accountability, Tina's team is doing quite an extensive piece of work on our leadership training and our leadership offer. A very wide piece of work that will stand us hopefully in better stead going forward, so we can give better leadership training to both our leaders and our aspiring leaders. So it's not a quick fix, but it's a long-term part of the solution to trying to get this right within our culture and getting our leaders and managers to act appropriately.
And I think talking to Region yesterday, a big part of the Region Speak Up Guardians role moving forward is to embed that culture of being able to go to the line managers and to help with that culture.
Yeah, that's absolutely right. Any other points? Anything finally you want to say, Mel?
No, just I'm really enjoying it. I love the job. And I've really enjoyed the portal work's been great to work on. Big credit to Stuart Dovey from IT, because he's absolutely just been at my beck and call. So I can't take the accolade for it. He's developed it in-house, which again is a great thing for the trust.
More than enough accolades today. Okay, thanks very much for that, Mel. Really appreciate the work that you're doing. I mean, from the perspective of the board, it's a really important role that you have. We're 100%, want you to succeed. You've got an open invitation to the board. If you feel at any time you think you need to communicate directly with us about issues, we're happy to have you here, because it's important that we get that as fast as we can. I hope that you're getting the right support as an individual, because it can be a very tough job in the sense of being the receptacle of everyone else's angst. I can understand that, so I hope we've got the right things around you. And thanks very much for the report, which we note. Thank you.
Thank you. I'm going to leave you.
Let's then move on.
Thanks a lot.
No problem. Thanks very much. Let's move on then to the Trust Management Executive.
Thank you, Chair. I'll take the paper as read. Happy to take any questions, but in many sense, there shouldn't be any surprises of the detail that we're covering, because a fair amount of it comes up through to the subcommittees. I think the attendance at the meeting and the contributions, particularly from our clinical leaders, as I said before, is continuing to grow and develop. And happy to take any questions, Chair.
You're pretty busy, I thought, given this list, and how you manage some of those agendas in the time you've got. I'd obviously need to take some advice from you about.
Well, not necessarily, Chair. I've had some feedback. So what we are trying to do is to refine the agenda wherever we can. Yes.
I see that Vicky's laughing. Largely because she's retiring soon, I guess. Okay. Any questions on this now? Let's move on. Okay. Let's move on then to the nursing and midwife staffing report. Vicky.
Some key points. This covers the period of August September. And I think you'll note that staffing was safe once mitigating actions were taken, which is obviously dealt with in real time. You will see a bit more focus and attention pulled out in terms of maternity services. September is always an extremely busy period in any maternity unit, but actually from COVID-1 to COVID-2 and some of the children returning to work, there were a number of COVID-related absences that added to the complexity of the staffing for particularly September more than obviously August. So that's described there. Happy to pick up any questions on that. And it does a forward look also in terms of the work that we are undertaking with HEE in terms of international recruitment and also return to practice, as well as the additional student placements that we're taking on board. You'll see the paper is set out in that we report to the board. So again, happy to pick up any sections underneath that. And I'll pause there.
Would you like, I mean, there was some, we've obviously had an issue in terms of midwifery staffing. And it got some rather, some newspaper coverage about it. Are we satisfied that we're on top of this now and we've got a decent way forward?
I think, Chair, it would be best to say that we keep it under daily review. The safety huddles that were already in existence to ensure that and community services are being managed safely is an ongoing basis, and hence the need for the reporting to the board to ensure that it has been safe. Were mitigated through the involvement and inclusion of the continuity of carer team and the community teams at time of peak challenges. So that blended model of staffing is relied on across any maternity unit, but particularly to be utilised during the period of September. I think the importance for the team, and this will play through the October report as well, which will subsequently come to the board and people in culture, and then it's important that we listen to concerns of staff who at times were quite in the unit, and obviously importantly communicate with our mums, and we've heard obviously 2 stories today, but actually listen to the concerns for patients, because at times the provision of care hasn't been as timely as it could have been, and that's we're watching that very carefully. Staff, which has been highlighted in the paper.
Thanks. Any other comments, questions? So we endorse the report and see it as assurance. Thank you, Vicky. Right, any other business? We don't have any. Peter Pinfield, I think, has had to leave us, so there won't be any questions. So I now declare the meeting closed.